Well, first of all, I would like to thank Professor Mariam for this brilliant idea and make this gathering with our prominent colleagues. And thank you for the discussions and for the introduction, because it will make my presentation easier. And I'm happy to have here with us Professor Hassan Bibi from Saudi Arabia. With his TB is, they have a lot of cases, and I have practiced in Saudi Arabia, most of my practice, and also Professor Ala Radwan, he has great experience also on this. And addressing the question of diagnosis of ocular tuberculosis, this is really a dilemma. Tuberculosis is one of the top 10 causes of death in the world. And extrapulmonary TB accounts for up to 20% of the cases. The problem is the exact prevalence is not known, and tuberculous uveitis affects up to 10% among all patients with uveitis. But pay attention to this figure: 92% of patients with ocular TB show no concomitant pulmonary TB. This is very important for our pulmonology colleagues. The diagnosis and the management of ocular TB is usually a problem. Why? Because of lack of evidence of coexisting pulmonary TB. This is why we struggle with our colleagues. And the variable clinical manifestations. TB is a great mimicker. It can cause any form of uveitis. And the absence of the global consensus. We have different practices in India, Saudi Arabia, and Egypt. And there is no internationally accepted standard. The gold standard, as was mentioned earlier, is the detection of Mycobacterium tuberculosis in the ocular tissues and fluids. But this is very difficult in the eye, because we have very low tissue load in the eye. TB, tubercular uveitis, is a paucibacillary disease. You can have only one organism causing the disease. How can you detect it? So it is very difficult. The other thing is the small size of the ocular tissue all the time. So we don't expect to have a positive microbiology test, even if it is a heavy infection. So this is the ultimate answer to the biopsy, and if you need a biopsy, you will wait for long. So my question is, for the uveitis experts here, what you will do if you have a patient with anterior granulomatous uveitis like this, and the quantiferon test is positive, what you will do? We have several questions. Is the eye problem due to active TB, or it is due to, if it is due to TB, is it due to direct invasion or hypersensitivity reaction? Treatment is different. Or is it due to another coexisting disease? You imagine how it is a dilemma, in fact. So we need to answer these questions in order to know how to treat this patient. The answer came from the COTS study, and as Dr. Mariam nicely illustrated, it was a survey-based clinical study that was put to address the knowledge gaps and to consolidate the expertise of uveitis experts in the world. And it included 81 uveitis experts, and I'm happy to be part of this with Professor Hassan. And it was a consensus and a survey. And they put strict criteria for each phenotype of uveitis in order to initiate anti-tubercular medication. I know this table is a little bit sophisticated, but I will make it simple. This table for anterior uveitis. But if you have a rapid look at this table, we insist here on having positive radiology. You must have a positive radiology. In all cases here, in this column, the radiology, you must have positive chest X-ray, and either the quantiferon or the TB in order to treat the patient. The second entity is the intermediate uveitis and the panuveitis. They are almost the same, and also we emphasize the radiology. You must have radiological evidence of either active TB or an old healed tuberculous focus. But in posterior uveitis, there are some exceptions, as also nicely illustrated by Professor Mariam. In the multifocal choroiditis, almost the same. We should have either test positive in addition to a chest X-ray. But we have exceptions: the tuberculoma and the serpiginous-like choroiditis. In serpiginous-like choroiditis, we can have only one test to justify starting a treatment. In the tuberculoma, we can have only chest X-ray without immunological test. So this study is, in fact, very nice. This is a summary, and the table is available online and on the article. But is it applicable in all places? I am part of the COTS, and I'm happy with that. But we have to think. 60% of the patients with extrapulmonary TB have no evidence of active pulmonary TB. 92% of patients with ocular TB show no concomitant pulmonary TB. We used to have simple criteria, and we published our publication based on this. And this were, in fact, I adopted from my mentor, Professor Khalid Tabara, and we did much literature. This was before the era of QUTS. And this is simple and applicable. The first is a compatible clinical finding. If you find granulomatous uveitis anywhere in the eye, the other thing, positive immunological test, either quantiferon or BBD, a positive therapeutic response to a full course of anti-tubercular medication, and of course, exclusion of other causes of uveitis. The last item is present in all the diagnostic criteria of all uveitis entities. I will show you some cases. When I run out of time, just please tell me. This is a 32 female patient with anterior granulomatous uveitis. As you can see here, P27 negative, and everything was fine. Quantiferon was positive, and the BBD was positive. And this is her CT chest. It showed an old healed bones focus. And of course, this patient is justified to be treated according to the COTS because we have positive radiology. The second case, and this is a 56 male patient complaining of pain in his left eye, and this is his findings. He has elevated intraocular pressure and mild anterior uveitis. This is his B scan, showed this vitritis. And according to this, I thought of viral etiology, unilateral anterior uveitis, elevated intraocular pressure. I ordered the routine workup, everything was fine. And the chest X-ray, CT chest showed the prominent high and higher lymphadenopathy, and his quantiferon was positive. So we have this criteria now. We have anterior uveitis, vitritis, positive quantiferon, positive chest X-ray, so there is no problem here if we apply this criteria. But look at this case, a 42 female patient complained of blurring of vision and floaters of 2 years duration. Her anterior uveitis was mild, and this is her OCT, showed macular edema and vitritis in both eyes. I did the routine labs, and the BBD test was done, and it revealed, this is written in Arabic, so it is 31 in duration, strongly positive BBD test. And the chest X-ray showed just increased bronchovascular markings, non-specific. So this is a summary of the findings. If we apply the COTS, we will not treat this patient because chest X-ray is negative, but the BBD is 31. So are you going to leave this patient without treatment? What happened? I treated this patient for anti-tubercular medication alone, based on what I learned. And after 40 days, this is the edema in both eyes, and this is after 75 days without oral steroids, and the edema subsided, only on anti-tubercular medication. And this is another case of multifocal choroiditis. Chest X-ray was normal, and this is the BBD. You can see how strong the BBD. So if we apply the COTS again, we will not treat, but we treated this patient also in the same way, applying the same criteria. I have several other cases, but the message here I want to convey: stick to the COTS, please, as far as you can. These are very good, but use also your clinical judgment and your insight. The other thing, in order to have a collaboration with a chest or a pulmonologist, you have to choose or select someone in your area. This is what I did in Alexandria. I have a eminent professor of pulmonology. I convinced him, I send him the publications, and then when I write the prescription for him, I don't prescribe the medication by myself. I write a report, I tell him, this patient has panuveitis, and the most likely diagnosis is ocular TB, please, for a 6 or 9 month course of anti-tubercular medication. And that's it. This is what we need to convey. This is the message we need to convey. Of course, it's very difficult to convince all pulmonologists, but at least if you have 1 or 2 in your region, you can collaborate with them. Thank you so much for giving me.
Thank you so much, Dr. Samir. Thank you so much, Dr. Samir, for this really nice presentation. So, Dr. Wati earlier stated that we're no longer an endemic country. So, this means إن إحنا هنعالج patients أقل. السؤال بقى إحنا patients بتوعنا أغلبهم we immune suppress them. أنا مش بتكلم عن biologic، بتكلم حتى immune suppression العادي. طيب نعمل إيه؟ وإحنا لو اعتبرنا إن إحنا مش endemic.
Okay, this is the knowledge which I have. المعلومات اللي أنا يعني بتعامل بيها إن إحنا we are not endemic or non-endemic. We are intermediate burden. Maybe this knowledge may be updated. Yeah, it's common. But I think what I learned and what I am practicing, if I have granulomatous uveitis, even anterior and a single immunological test, I go with the treatment.
رأي حضرتك يا دكتور وجدي.
وطبعا الجزئيه اللي اتكلمنا فيها قبل كده موضوع الليتنت تي بي انفكشن، ودلوقتي بقى في جايد لاين كامل للتي بي تي. فدلوقتي حالات الاميونولوجيكال تريتمنت او اللي هتاخد انتي تيومر نيكروزس فاكتور تريتمنت لازم نعمل التيوبركلين سكين تيست او الكوانتيفيرون. ودلوقتي احنا في الايرا بتاعت علشان نعمل اليمينيشن للتيوبركلوزس لازم ندي التي بي تي او التيوبركلوزس بريفنتيف تريتمنت، والريجيمنتس بتاعتها معروفه، يا اما اي ان اتش 6 شهور او 9 شهور، او اي ان اتش مع ريفامبيسين 3 شهور، او احنا دلوقتي جبنا الريفابنتين مع الاي ان اتش 21 دوز ويكلي لمده 12 شهر. في العيانين الاميونو كومبرومايز دول عندنا كاتيجوريز ليهم، سواء تشيلدرن اندر 5، عيان اتش اي في، عيان هياخد انتي تيومر نيكروزس فاكتور تريتمنت، عيان هيعمل اورجان ترانسبلانتيشن، عيان رينال اندر ذا رينال دياليسيس. العيانين دول لازم نعمل كوانتيفيرون او نعمل تيوبركلين سكين تيست. وانس بوزيتيف نعمل رول اوت للاكتف تي بي برضه الاول. وانس ان مفيش اكتف تي بي نبتدي نوفر التي بي تي او تيوبركلوزس بروفلاكتيك تريتمنت.
شكرا جزيلا لحضرتك. I have one comment بس زي ما دكتور سمير قال، في حالات الكلينيكال بيكتشر مش كونكلوسيف، والكونكلوسيف هو بيكون الثيرابيوتيك تيست، هي دي اللي بيكون عندنا فيها الايشو ان احنا نقنع حضراتكم نصرف العلاج ونشوف هيحصل ايه للعيان.
برضه الستيتمنت بتاعت الدبليو اتش واضحه ان الثيرابيوتيك تيست نوت ريكومندد علشان الحالات اللي حصل منها كتير جدا مالتي دراج ريزيستنت، ودي دلوقتي الحمد لله لما بطلت الحمد لله يعني البريفلنس بتاع الريزيستنت تي بي قل جدا. يعني انا عايز اقول لحضرتك احنا كنا في سنه 2000 كان عندنا 12% من حالات التيوبركلوزس دراج ريزيستنت، احنا وصلنا دلوقتي ل 1%. فوانس ان انا سبت الانتي تيوبركلس يوزد راندوملي كده الدنيا حاجه. وزي ما استاذنا قال يعني اعمل اكسكلوجن للاذر كوزز وبعد كده نقرر.
طيب انا بس عندي سؤال او كومنت على منطقه الكوانتيفيرون. لو كان الكوانتيفيرون نيجاتيف قبل بدايه الانتي تي ان اف، احنا في التامين في ريجيمنت كده ان احنا لازم بنعيد الكوانتيفيرون كل سنه، فلو الكوانتيفيرون تيرند من نيجاتيف بقى بوزيتيف والعين على الانتي تي ان اف، احنا عاده بنوقف الانتي تي ان اف لمده شهر ونبتدي الانتي تيوبركلس ويفضل ياخده برده من 6 ل 9 شهور. هل ده صح ولا مش مظبوط؟
طبعا ده صح حضرتك. وانس الكوانتيفيرون كونفيرتد لبوزيتيف ده معناه ان العيان خد انفكشن وليس ديزيز انفكشن، فبرضه نعمل رول اوت للاكتف تيوبركلوزس، نبتدي معانا البروفلاكتيك تريتمنت. مش هندي من 6 ل 9 شهور، احنا بنفضل للعيانين دول ياخدوا اي ان اتش ريماكتان لمده 3 شهور. فده الريجيم المتعارف عليه. عايزه حضرتك شايفه ان حاله العيان ممكن تتدهور لو هو وقف خالص، ممكن بعد شهر فقط نبتدي الانتي تيومر نيكروزس فاكتور تريتمنت تاني ويكمل البروفلاكتيك برضه لمده 3 شهور.
Thank you so much دكتور وجدي. Thank you نيال. دلوقتي دكتوره دعاء مأمون هتقدم لنا